Oh, I still don't know what Lisa's saying. She's talking, but I can't hear her.
You know what we didn't have last week is I didn't have papers. Hold up. All right, should we get started? Okay. Uh, Today's discussion is mostly about intubation and roles during an intubation process and ventilator, a little bit about ventilator settings, but just the basics. Because so I've been doing this 2.5 years. Was ICU nurse for 20, and most of what my training for acute care nurse practitioner program, as far as vent management, didn't go very much further than like CCRN training, like how to recognize if you're hypoxic, go up on the PEEP, COPD type responses to the vent, and what kind of changes you would want to make to blow off carbon dioxide. Not anything major. The rest of that has been, for me, has been on the job training as far as clinicals with Shabir and Samana and Rayburn. And then when I graduated and working here has been just communicating open line with the respiratory therapist and saying, yeah, I'm new, teach me. And feel like every 6 months I get a little bit bigger understanding of something, and then all of a sudden I discover something new that I know nothing about on a vent. I'm like, holy crap. I didn't really understand compliance, or I didn't know mean airway pressure was a thing. I knew plateau pressure was there, or peak pressures. And then I discovered mean airway pressure. And what does that mean? And so I keep learning. I keep asking questions. First year and a half, as far as intubation goes, is just my intubation experience in during nursing or nurse practitioner program was just what I got out of anesthesia, which is usually just a scary day. I did 3 8-hour days in anesthesia. I had 8 attempts or 7 attempts. So that's 7 airways you get a look down that you didn't know anything. Pass or fail, whether I got them intubated or not, is that's up for grabs. But that was 7 different anatomies that I got to see that I'd never seen before. Same thing the next day and the next day. So if I got 15 or 16 possible intubation attempts in 3 days, that was a lot of experience. Because day 1, I didn't know what I was looking for at all. So that's my experience. After that, it's been on-the-job training opportunity. Like, hey, this guy is in a C-collar, needs intubated. Audie was standing next to me. He says, why don't you just take a quick look, let the glides go. And we did, and we got lucky. So since then, I've started looking and wanting to know more every time I intubate. What could I be doing different? How could I improve the situation? What did I not think of? Every single time. So I review it. And every morning when Rickleman comes in and I say, hey, I tubed that guy in room 3, blah, 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 and I tell him about it, we debrief on it after every intubation. And he always asks me, what could you have done different? And I have to think about it. And there's always one more step that I could have done. And usually it's a preventative step. What if this happens? So intubation process is mostly trying to predict failure and having plan A, B, C, and D. There's a score that I use. There's about 4 different types of scores to predict a person's airway. The simplest one I found is called Lemon. The L is just the look, just looking at the face and the neck and the anatomy. E is evaluate. It's called a 3-3-2. I have a picture for that. I got a lot of pictures. The 3 is, can you get 3 fingers in the mouth? The other 3 is, can you get 3 fingers from here to here? And then the 2 is, can you get 2 fingers from here to here? That shape apparently has been evaluated and shown that it's most likely successful, easier intubation. Mallampati score is, can they open their mouth? And how much of their mouth can you see? And most of our patients are just laying there. You can't do it. But if I pull the chin down, maybe I get a little bit of motion. But most not. So already a lot of our patients' mouths don't open. They have no neck. They have a horrible Mallampati score. O is obstruction and obesity, and N is neck mobility. Most of our patients are horrible intubation patients. So here, pass stuff around as you go. And here's a picture of a woman putting her hands in her mouth. Important to know. She's dedicated. She's like, I don't want to be in this video. I told you. So that's prediction. You're looking and trying to assess and going, oh boy, I think I can do this. After that, it's going to be things that's important is height and weight right away. These are all the things that are kind of like in my head. Height, because I'm already trying to figure out once I'm intubated, we need to know what kind of vent settings. There's a ideal body weight, and there's tidal volumes for men and women based on height. Up to Date has an app, and I have it on my phone, and then I have that saved, those two tables, and I printed those off and I'll pass around. And it goes all the way up to 7 foot. So for example, if the average woman's height is around 5'2", 5'3", your tidal volume would be around 400. We'd use 500 a lot for men, but that's like a starter, but that's honestly if they're like 5'6". Anybody taller than 5'6", it goes off. So, but height is important. Weight's the other, and knowing the patient's weight as we're getting started for drug dosages. After that, it's potassium. So if we're like, hey, we're going to intubate, if you can tell me, hey, Wayland, potassium's 5.1, you're like, hey, this dude's about 5'6". Hey, this guy weighs 100 kilos. That's very helpful for me, because then I'm like, drug dosage, not going to use sucks, or if I do, I'm going to have to watch that K. And then I can already figure out drug dosages right now and assign a nurse to be the drug person who's going to manage the drugs, draw them up, bring them in the room, and push them when I say, okay, I'm ready, go ahead and give that. And then I can already figure out vent settings, put them in that way, because the first thing RT is going to ask me is, what vent setting do you want? I'm like, I'm still trying to figure out if I can tube this guy. And then I usually, behind the scenes, I'll call and find out who the anesthesia person is on call and what their pager is. And are they in-house or are they not? Because if I feel like it's going to be a tough one, I want them on ready. So here's some anatomy. One is kind of what it would look like if you were looking down there. I got a few different pictures for anatomy. The epiglottis, this looks like this big piece right here. And what's in this vacancy above it is the vallecula. Difference in a straight blade and a curved blade is that curved blade doesn't go and pick up the epiglottis. It comes up short and it goes in that space, and it's curved and then goes in and lifts, and that epiglottis should come up with it. If you're using a straight blade, you're going to go deeper and on past and catch that epiglottis, which is kind of hanging out there, and it's going to lift it up so that you can see the airway underneath it. This is an open airway. Sometimes this thing is hanging halfway down or all the way down and just hanging like a car hood, and it needs lifted up. And if you can't get it lifted up, then at least if you can see the esophagus is down here below it, you know the airway is hidden behind it, and you've got to try to. This is why camera is a big deal, and having different curved blade options is a big deal. And after that, it's what are you comfortable with? So here's some pictures. So in anesthesia, direct laryngoscopy is not. This is video assisted laryngoscopy, and then direct laryngoscopy is just the regular Miller or Mac blades that you see, and that's preference. Like Leonardi in anesthesia uses a Mac 4 for everybody. He figures if they're shorter airway, then he'll just not go in as deep as it and use it like a Mac 3. And if he needs to, a Mac 4 is pretty big, he'll just go in a little further and actually just use it like a Miller and pick up the epiglottis. He'll either come up short or go deeper. Either way, he uses one blade for everybody. Dr. Rayburn prefers the Miller 1 or 2, and he likes that, and he uses that for everybody. So if it's really an anterior one that he needs, he just does the same thing every time. It's good for everybody, and he uses that. And I know his view though when he looks like it's just a tiny little, because he has to get right in there and really see it. Then he straightens out the tube and does kind of a straight shot rather coming in curved. Leonardi, back up to him when he uses the curved blade. Then it's so aggressively curved that Mach 4 when he takes his ET tube with no stylet in it, folds it in half. The ET tube bends it in half, lubes it, sticks it back in the package, leaves it on his anesthesia card, and waits. And when it's time to intubate, he gives his drugs. Look, takes that out of the package. It unfolds like something a plastic tube would, but folded in half, and then he goes there. It works for him. Works every time. Shoot, I think I saw him do it 5 years ago. I'm sure he hasn't changed. So, so I learned to do I had about 15 attempts over there with direct, and then when I first started here, first month or two, I tried with direct, and then eventually, after I used the glide scope for the first time, I'm like, oh my god, so easy. Not easy, but it was big difference between two different styles. And this one works really well for me, so I liked it. Then we have the glide scope Go, which is it has different blade options, and I'll compare those. The Mach 3 and Mach 4, and the Low Pro S, which is a aggressive angulated. It comes very interior, almost like a J. These are bigger and more angulated than our Mach 3 and Mach 4 for these. So it kind of makes me feel like the more anterior difficult airway, I'm gonna would switch to this thing because it's gonna make that curve better than this one will. If somebody's really got a curved airway. There are algorithms. I love that. But good news is they all feed to one algorithm if everything fails. So if you know the failed airway algorithm, that's probably what's most important. So there's a universal emergency airway algorithm, and the ones that are mentioned here, because then there's so universal emergency airway algorithm. Unconscious, is your patient unconscious, unreactive, and near death? Yeah, they are. Then you go to the crash airway algorithm. Good news, if that fails, you go to the failed airway algorithm. You probably know that one too. And then, are they not unconscious, unreactive, but they're just tuckering out? We have a lot of those too. Then you go to the difficult airway algorithm. If that fails, is it a difficult airway? Yeah, it might be. Maybe they're obese, no neck mobility, no neck, can't open their mouth much. Yes, then you go to the difficult airway algorithm. If that fails, you end up back at the failed airway. If all of this is fine, they're not unconscious, still breathing, but wearing out, airway looks fairly predictable, that it's probably not too difficult. Then you do rapid sequence intubation. If that fails, go to the failed airway algorithm. Everything ends up at the failed, which recommends video-assisted laryngoscopy, yell for help, which is anesthesia. So you call for anesthesia, you use the video-assisted laryngoscopy, or flexible endoscopy, which is our bedside bronch attachments, which is before that we didn't have that, and before that all we had was anesthesia or yell for ER because we didn't have anybody here. So we have three things in place. Anesthesia is probably 15 minutes at home in pajamas. The flex bronch is back there. This is right here, and ER positions are still here. If we get in trouble and say, "Can you run upstairs right now?" It's life or death. I need your help. Don't go. Come up. This one is another main airway. Same thing though. Needs intubation, unresponsive. Maybe not. Predict airway difficulty. If it's not too hard, we're going to go with rapid sequence intubation. Let's attempt the intubation, but everything ends up down at failed airway if you need to get in trouble. But I can pass these around too. Crash airway, you would think that one would be the exciting one, but that one's basically maintain oxygen, attempt intubation. If not successful and fail to maintain oxygenation, then you go to paralytic. Well, we get into this pretty quick. This is kind of where we live. Like, I think this dude needs tube. Oh crap, you're right. Well, let's get everything set up. Let's give him some sedation, which is the induction agent. And then after you give the sedation induction agent, which is usually Versed or propofol, think your screen's going to time out again. Etomidate, Versed, or propofol are usually the common three. After that, you're going to give a paralytic, which is going to be succinylcholine or rock. There's a difference in the two. Succinylcholine kicks in quicker, maybe 30 seconds, 30, 35, 45 seconds, and then will buy us a shorter amount of time. It has a short onset. It's going to be quick, and it's going to wear off quick. And there's some fasciculation that may, if you've never seen it, may make you think that your patient's seizing or something at some point in that. Not everybody's the same though. Rock can take a minute or more to kick in, but not always. Sometimes we've seen it kick in pretty quick. But rock can take, and then it'll sit around and maybe last you 30 to 60 minutes, which is really helpful. And then anesthesia, I'm not that creative yet, but anesthesia sometimes mixes their paralytics. They'll do a little bit of sucks, a little bit of rock, and plus they always give that induction agent. Propofol is great, but you got to watch your blood pressure, of course. You know, if you're like 130 systolic or higher, this is just picking a number because I've seen it. It's like, it looks like it works really well, and usually don't bottom out of pressure. If you're 100 or lower, propofol is kind of, so you got to, having seen a lot, some of you guys have really seen a lot of shit over the years, it's picking the right drug and kind of predicting whether like these sedatives are going to knock this patient's pressure out. So having people have jobs in the room, I've learned what makes me feel more comfortable is knowing the room, everyone is in place, because it's hard to feel like you got to run the room and manage airway, like because if you're at the head of the bed. So I like to put somebody on hemodynamics, and I know I've done that, for example, with you. The first time I had an aha moment, I was like, hey, Holmes, can you set the blood pressure to every 3? You watch, monitor, and be the hemodynamics person. So start a liter of fluid, run it at like 250 an hour or something, because even if this takes 30 minutes, you're going to get 125 in. It's not like you flooded them. But if we need that way, I've got a bolus set up. At any point, she can just hit 999. And I ordered Levifed PRN. It comes up, so we're not pre-mixing it right now in a disaster moment. It's already here. And so if I put one person on that, and then I say, hey, draw up 20 of etomidate and 50 of rock, have it ready, and then you're my person, and then you're like, and we usually talk about, is it that IV site good? Do you trust it? And do you have a second one or not? At times at Vanessa, sometimes you can't just throw in a second, but I know this one's good, or this one's iffy. We had one with Pete and I were in on one where we gave the drugs, the patient wouldn't go down, and he's like, "Is you sure?" And he said, "Went in, man. I don't know." And it's like, "Try the other one." And I said, "Do it again. Let's do another." We're using propofol. We'd done 50 of propofol, and I gave 100 of sucks, and nothing happened. Oh, this isn't good. We're on BiPAP, and then we switched. I said, "Do another 50 of propofol on this side, and give 50 of rock," and she went right down. I was like, "Wow, that's like." It looked good. It didn't show us it was infiltrated, but doing the other side, it all came together. So having somebody on hemodynamics, somebody on drugs only, that's your job. You go get the drugs. I'll put in the order. You get the drugs, draw them up, stand there. Have an RT on this side with suction set up and holding the ET tube. And then usually on this side, you've got a BiPAP, for example. If the BiPAP's already on, I like to keep it on because that's non-invasive ventilation, and it's working better than nothing. It's unpredictable when we remove it and start bagging, and it's hard to replicate 18/14 and you know what I mean? Because we're creating so much PEEP that when you take that mask off, you almost can't replicate that. You want a PEEP valve on that. We have some new RTs in the department too that are still learning. I have to make sure we communicate with them. You have a PEEP valve, and I've different every time I do one. I learned something new or something I should have. For me, it's going in and out of tunnel vision to wide vision to tunnel vision again. And I have to focus and then expand my focus. The tubing was going through the mask and then to the BiPAP. And we had made attempt and the airway closed. And it was like, oh crap. So we had to stop and bag. And when she went to stop and bag, the mask was still coiled through so we couldn't back. So then I had to just go for it, and the SATs were dropping in the 40s, and it's just, screw it. Or give it here, and we're going again. And that was, so those kinds of things, make sure everybody has their job. So on this side, that RT is going to have to have the end title and the holder that she's going to do, and be prepared to bag at any time, and then assist with moving the BiPAP out, which if a nurse is in the hallway can come in and grab that BiPAP and unhook airway and oxygen and yank it out, and then roll the vent in, then they can set up their vents. Vent is on battery backup a little bit, so they can preset their vent settings. So all they have to do is roll it in, plug it in, hook up the O2 and air, and then switch it over. We can, in our ARDS patients and down here, I've noticed we're losing lung recruitment as we switch from AMBU to the vent. I keep losing, like I'll have 92%. We've bagged them up, pop them off, put them on vent, and they go to 80s, 70s, 68, and I'm like, what did we do? So they're talking about either just put my thumb over it. I'm gonna try to remember this. If I pop off the AMBU bag and put my thumb over it and wait, so I don't lose that recruitment that we just got, and now I'm starting all over as we're trying to set up the vent to match them. Because in the end, it ends up being, I've lost recruitment, and I spend the next 20, 30 minutes, really scared, like, oh, crap. Here's the crash airway. Here's the failed airway, the one that's everything. And there's the difficult airway. This is, yeah, right?
I hope you use the blessing computer, not your own.
I use my own. I was on my phone. I was sitting in the kitchen at 10:30 at night on Thursday night or Wednesday night, clicking save print. Yeah. You know how it is. Put the kids to bed and then you start working on a few things here and there. This is what I use. This is that table for choosing tidal volume, and then height, and then tidal volume. 8 mils per gig. Where we start, 7, 6, 5, and 4. So I work my way back based on, so I can say what I've prescribed. So for a 5'3" female, tidal volume for 8 mils per kilogram would be about 420, and that could be anywhere from, our vent settings will only let you go up by so many increments, so it may not let you put in 419. So it's either gonna be like 400 or 450 or something. And the things I look at on the vent, that top right-hand corner of the vent is, you're looking at peak pressure, rather than mean airway pressure was a new one, and that's supposed to include all the pressure that is from the alveoli through the small and large bronchioles, that you get that an idea of what is the overall average of pressure throughout the lung system. And I read an article on that, and patient survivability to 90 days to discharge was the window of survivability. Those that had the worst outcome and didn't survive the 90 days had mean airway pressures of 13 or greater. And those that survived was 11 to 12. It's a pretty tight window. And so then I went in and I started looking at vents. I just walked the hall after I read that article. I'm like, 19, 13. Holy crap. How do I improve that? What's acceptable? And is that real? You know, and because the 500-pound guy we had anesthesia come help me when she tubed in room 4, when he dropped out, like when we switched him over, he had him bagged good, and then when we put him on the vent, he dumped out again, and his sats went clear down in the 80s, and I had a PEEP of 24 on him. Tidal volumes of 400, and the first things I played with was I set him up what makes sense, right? Tidal volume of like 600. He was on his BiPAP, it was like 18 over 14 for him. So I knew he needed a PEEP of at least like 14. So how do I give him a PEEP of 14? Make sure I'm getting a tidal volume that keeps open all that space so I don't get atelectasis in like 12 hours and get a chest x-ray. And then look at the pressures, and then like his mean airway pressure is like 21 and his peaks are like almost 40. And I'm like, am I going to blow a lung? So then I've got to go from 8 mils to kick down to like doing ARDS type stuff, like 7, 6. So then we end up at tidal volume of 400 because I started playing with that first. But I need to go up on the PEEP because he's hypoxic on 100%. The only thing I can do is go up on PEEP. So I go, I'm 18, I'm 20, I'm 22, I'm 24. Let's hang here. Let's wait. The next, if that's not working within five minutes or so, it's time to give rock and paralyze him. And by 30, 60 minutes of complete, known, predictable ventilator compliance. That he's not struggling, coughing, anything against that ventilator. So I'm getting guaranteed volumes. So I did that next, and then that helped after. And the other thing we've learned to play with, we look at the compliance. I don't know what's the magic number, but if you're 30 to 60 in there, you're doing pretty good. Our COPD patients that really love to be on a ventilator, their compliances are like, I've seen them 75 to 100, which is blew me away. But that guy's was like 16. It was horrible. You give the paralytic and you'll see it go up 20 points. That was interesting. So we needed to knock him out and really make sure the settings were working and give him time. And then if we can, some people have different opinion than there's how long of inspiration, how long of an expiration, and you can shorten or lengthen it based on, do you need to blow off more carbon dioxide? Maybe his CO2 is 60. Maybe his CO2 is always 60, and I shouldn't focus on that because his PO2 is 40. So what do I need? I need longer inspiration and then a shorter expiration because he's going to die of hypoxia before I even care about his CO2. So we lengthen the I time, and then we play with the trigger, which I don't know how to do that. And the I times I'm just now starting to figure out. So I usually just call RT and say, get back here. We're not done. I've done what I know, and it's not working. Help me. And then if it goes beyond that, when like Desiree or whoever, or Beth, we're just standing there looking at each other like, I don't know, man, we played with everything. Then I put Shabir or Rickleman on speaker. And I take a picture of the screen and I send it to him. And it's like, help, man, I'm stuck. Another interesting case was a really bad COPD a few years ago. That young man with trashed lungs from drugs, like a fibrosis type, and he acted like a horrendous COPD patient who was 30s, and we didn't know any history on him, but he looked, from a ventilator standpoint, if you had a sheet over him and never saw him, you'd think he was 75-year-old male who had smoked 2 to 3 packs a day for 50 years. And that's how the ventilator, he had almost zero compliance. And for his height, his tidal volume should have been like 600, but he was only taking like 175, 150. Couldn't, and I've actually put my hands on his chest, and it did not rise and fall with the vent. Oh, what is, I get a chest x-ray. Do I have pneumos? No. Is this thing working? Is it on? Start trying to go through the dope mnemonics, the dislodgement, obstruction, pneumothorax, and whatever the heck E stands for. I went, tried to go through that, and we were lost. I called Shabir, and he's like, if he's only taking 170, you need to turn tidal volume all the way down to only what he's taking. He's overinflated. He is complete. His chest is full. It won't expand. It's already full. He is so hyperinflated from the COPD, and there's zero compliance in these stiff lungs, so they're not moving. It's just you've got trapped air in there from being bagged at probably 20, 30 a minute on the way up here in the elevator and all that stuff. Some things I've read, it's kind of scary. If you just pop them off and let them, you gotta let some of that gas escape. You might have to do that a few times every few minutes for a while. But felt like we were losing him in front of us. So he says, shorten the I time, whatever you have to, and lengthen the E time, and paralyze him, and let all that gas just, so his inspiration's like, and then and just let it blow off. Things you could do if you turn the rate up too much, that shortens that though, because you're trying to ask for 30 breaths per minute, and it can't do, like, maybe you still only need 12 to 15 breaths per minute, and you just need a nice long expiration to try to blow that off and get tidal volumes back. That one wasn't a survivable story, unfortunately, but we sure tried hard on that one. And that was I'd never been in that. That was just something that will always stick with me. I don't know if I'll ever see that again.
Underlying, it was like COPD.
It was, yes, and it was
fibrosis.
yeah, drug-induced fibrosis of the lungs from smoking.
With all that, there's just no way.
So methamphetamine smoking for many years trashed his lungs, and he was so young. So that's one I don't want to forget, so I can apply it should I ever be in that situation again. And then ours, with our COVID stuff, knowing the difference between like sepsis ARDS seems to be different than this viral COVID ARDS is a little different. Never thought I'd even notice a difference in my life. Now there's kind of two different. They act different on the vent a little bit. I never thought I'd see this much ARDS, so that's an interesting thing. And then pulmonary edema type stuff. I don't know. And I've really learned those lungs can take a lot of pressure and not blow. Because I would have always got nervous. Now we're seeing all kinds of high pressures. Here's these things. Equipment. Hang on. You want?
Yeah, I can.
Just for example, so recommended says, what do you want?
Turning, you guys.
What makes you nervous in the whole airway? Like, what's the one thing that makes you? It's managing the room and managing the head of the bed at the same time.
Nurse
Yeah.
and provider, whereas he's never.
Well, it'd be a lot easier if I was just blind to how all this stuff works. You're like, but just do the things, get the stuff, get the drugs, do the thing. Where are the drugs? And you just stand there and bitch at the head of the bed. Not helpful. And then, so the charge nurse in me is like, do I have an experienced charge nurse? Because sometimes you do. You got somebody that can just run it. You guys are good. You're gonna say, what drugs do you want? Do you want me to go ahead and get the vent? And RT's gonna say, what vest settings do you want? Are you gonna use the glide scope? Are you gonna do number 4? I'll go get that for you. Or did you want to use the go? No. So I'm gonna put a new IV in over here. This one's kind of iffy.
Best team ever.
Best team ever. I'm gonna get some coffee. Who made coffee? Call me when I'm ready. And then sometimes we have new crew. And there's somebody coming tonight this week, right?
Mm-hmm.
It too. So. And then sometimes you have 3 RT students in the hallway. Can they watch? I'm like, yeah. And good luck. Cheer me on because I'm still kind of new.
Get the pom poms.
This is a bed. These are feet. This is a head. And because your thoughts is probably something opposite, right? This is you. This is where I'm used to standing for about 20 years. Right there. Pushing drugs. Managing pump, watching monitor, and listening, right? This is what I stood for 20 years, and now this is how I see it and think, and then hallway, and who's out here, and crash cart, and who's a runner, right? And I have a BiPAP here. I got the vent in the hall that's ready to come in. BiPAP's hooked with Air and O2 and plugged in. I got an RT here with an ambu bag ready, right, and the end-tidal CO2. Over here I have an RT, because usually there is the supervisor always comes. The most experienced one in the building comes, and we have Courtney who's still learning a lot. So I'm like, you might want to go get, so they either get Beth or Desiree or John or somebody. And so I have an RT here, I have RT here. RT here is like. And then someone is already like, do I have suction, yonker, and how many ways does that suction fail? Right? There's like 5 ways it fails. Ambu bag fails. Is it hooked up? Is it on 15 liters? Is the mask hooked to the end of it? And do you have a PEEP valve on it? Because we need PEEP on almost all these now in the plague. And do I have good IV sites on both sides? Then I have the monitor. And I like having an RN if we can do it, that is managing pumps, so IV fluids and a pressor if needed, and monitoring this every 3 minutes. So oxygen, tell me what O2 and BP and heart rate, because when O2 drops, our heart rate goes right behind it, and we're in deep shit. And then whoever my the drug RN, like, so I can clearly say, because otherwise 3 people I've learned, 3 people are going to ask me what drugs you want, and then it's like, well, she's getting it. No, I thought I was getting it. My bad, my fault. One person. Can you get me 100? So if I do propofol, because etelmidate is always 20, seems like propofol is always 100. Only give 50 at a time. So and it's really going to be based with something really. And most of the time, I can give 5 mils is 50 milligrams. We can give 50 of propofol and see how they do. That's the difference in the RSI. If I do 50 propofol and they just totally, I'm like, oh, let's look. Awesome, we're good. Let's go ahead and go. And if I can go for it, I don't have to use a paralytic. Great. Other one is Versed. The other one is ketamine, which I haven't branched into yet, but it has its place. And its place is it's easy on the hemodynamics, and it's great for asthma. Really bad respiratory cases. So if you're like, I got this 24-year-old girl, and she's, and it's definitely respiratory alkalosis are blowing off all this CO2. We're hyperventilating. Nothing's working. It's time to protect her. Ketamine is supposed to be a good drug. And I think it's a hell of a lot more dosage than what we usually, everybody's afraid to use it, so we underprescribe it. And then we say it didn't work. That's what I've seen. That sounds like it. Yeah. It is. Use me like you're supposed to, and I'll work. Versed good. Propofol is good. Versed is going to probably be more like 2 to 4, and we're going to have to repeat. You know, Tomidate works, but then they always say, be careful when you give it Tomidate. Sometimes the jaw will lock. I don't know the path on that, and I hadn't seen it. I was like, this works great. Why haven't I been using this drug?
Accommodate.
Yeah. And then it did it. And I was like, awesome. Tomidate's saying, oh, she's relaxed. Sweet, we're bagging. Want to go ahead and try? Sure. That's it. It's not moving. His mouth is not moving. Oh, crap. And then what did I do? We had paralytic right then. Give 100 of sucks is pretty good. I think it comes in 125, right? A vial or something. But 100 of sucks usually works pretty good. Knock them out. And then we just intubate. So if I know height and weight and potassium, then we know what kind of drugs to pick. But 100 sucks or 50 for paralytic, then it's 50 for rock and 100 for sucks. Works pretty good. What my experience has been so far, in a short amount of time. Sucks will buy us time. If we're really having trouble and can't get it after that, but we can still bag, and a few minutes go by, we may have to give another round of sucks. My end goal is usually, can I tube them with the induction drugs? Is good. The other thing I've had happen is we gave the drugs, the induction drugs, the sedative. They went to sleep. Life is good. Open airway. I'm on here. I can see the camera. I can see the cords. I'm passing the tube, and it's going great. And as soon as this tube got right to the cords went. They snapped shut, like they spasmed closed, and they were done. I'm like, holy crap. And I couldn't believe what I saw. I'm like, did you see that? And the RT's beside me, like, yeah. Shit, who's got paralytic? Again, having both these drugs drawn up with the nurse that's standing there doing nothing else. And I'm like, give paralytic. Now. Paralytic goes in, cords went. Like, oh, thank God that happened. Holy crap. And then I tell Rick about in the morning, he says, that's why you have all the drugs pulled up. Because a year and a half, 2 years ago, I wouldn't have done. The RSI was like, middle of the night. Anesthesia, everybody was against it. Now it's like, and they kept saying that's what's recommended, though. That's gold standard. So now we just do what we want to do, which is to do the right thing. So paralytics that I've been afraid of have saved my ass, actually, in a few cases. So this is the things I see. So having an RN on drugs only. and having a runner in the hall, and having an RN on hemodynamics if it's possible, of course. I know nothing's always ideal. Sometimes it's just you and one other person in your patient time. You just do what you gotta do. And having two RTs, one on each side, which is good because they can troubleshoot together. Oh, this thing's broke. This didn't work. Oh, crap. Well, all right, there's another one in the storeroom. Page so-and-so, and then they go and bring something else. There's some things happen. Did I leave out an RN job? After this, it's post-event stuff. So switching over, if we're using a lot of PEEP on the BiPAP, then I've got to play with the vent settings, and we'll put in the initial ones, like based off the tablet, the chart, and then and then if they are deoxygenated, I'm gonna try to remember to plug the end of that tube when we pop them off with the hand boost, so I don't lose recruitment. That's what I think. The other one they've talked about using a chest tube clamp. Those are hard to find. And clamping the tube.
Oh, you steal some?
So that's because we talked about that just the other day.
Yeah.
Yeah. And the other thing is intubation with cannula. We used to take everything off the patient. Intubating with if they're on 6 liters or something, or they're on a high flow, turn it up to 15 liters. Let's hyperoxygenate if we can. Build as much. The longer you're on 100% of FiO2, the longer window, 3 to 5 minute, like reserve. You're creating a reserve of oxygen, hopefully. But these patients are so sick, they really don't have much reserve. But if we can give them something, it might even buy me 30 seconds. So they don't plummet so darn fast. So if they're on BiPAP, I leave them on it until the drugs are in effect and in them, and we take the mask off them too. If they're on high flow, leave it on through the whole thing. The whole thing. Don't take it off until we're bagging, done. Leave it on. That works pretty good. And if we're having trouble, like there's other things, the nasal trumpet is there. So let's say things go wrong and we don't get them intubated, we can put the nasal trumpet in and bag, and then that, because if the tongue's occluding the airway because they're paralyzed and the tongue's just going to fall back. It's a muscle, it's just going to fall back. You can use a nasal trumpet. LMA, we talked about that yesterday a little bit, and I haven't used a lot of those, but it's there, and we can deflate it, we can lube it, stick it down in there, and then bag and protect airway that way until we're ready to make a second attempt and have anesthesia on their way in. So trumpets, the oral plastic airway, go in there too and turn. Sometimes that might be helpful in our BiPAP patient who's including their own airway while they're BiPAP. I've put in trumpets and kept a bad COPD or overweight off of getting tubed, because we came in and put in a trumpet and put the mask back on, and on the BiPAP machine, I watched the minute volume go up and tidal volumes go up. So I'm seeing a guy whose tidal volume on the vent would be like 600, but on BiPAP, he's pulling 300. The minute volume of like 6, which is not enough. And then I put the trumpet in because I play with it, and I kind of realized if I lift his chin up or something and the tongue's out of the way and jaw thrust, and he improves, and I see the volumes go up, tidal volume and minute volume. I'm like, oh, okay, now we could blow off CO2. Let's put a trumpet in. Put the trumpet in. 4 hours later, we get gases, and it's like, finally, you're doing something no one on the floor could do. It's like, sometimes it fails. It doesn't matter. You just get anyway. But that's that. Toys. The difference. The lights could go what most of your students have. This
You've got a
fun little toy lets you go right through where you need to go. It's angulated. There's a 3 and a 4. 3 is smaller. And you say the 4 is like for 40 kilos and up. If you're ever involved in setting this up, it slides in, and then when you're in there, it'll actually, if you push a little further, it'll flip. If you notice, the camera ends here, and you've still got almost a thumb's width further of plastic. So where your camera ends, you may think that you're, usually you tend to intubate. You go down with the blade too far when you first start using this thing, because you think your eyes are the camera.
you have to remember, there's a whole nother, almost a full thumb's width longer than the camera. So if you're clear down there and you're like, where did everything go? All I see is tissue, and back up, back up, back up, and then everything will come into view. So having learned that mistake, don't go in all that way. You start at the top of the mouth, I scissor the mouth open, and then slide that thing in slowly. And as you get to the back of the tongue, then look up at your screen. Keep coming so you see what you want to see, and so that you can see anatomy as you go. So when we passed around some of this stuff, you want to look for some of that, like, oh, there's the back of the throat, there's the back of the tongue. Like, oh, now I see, okay, the epiglottis, I see false chords, I see chords. Okay, we're good, great. And but in the beginning, it's like, look, I'm like, I don't see anything. Everything's a mess. Back up. You've gone too far. So remember, this isn't the end of the toy. Further deep. Switching to a 3, when I've had to do it, is usually because the mouth is just so small and there's not enough room to get in. When you intubate with this machine, you don't ramp the patient in the head way back. You just want them flat, just neutral. Take the pillow away and leave them neutral on the table or on the bed. I mean, and that's it. If you ramp them, like for direct, Mac 4, Mac 3, like for direct laryngoscopy, not video assisted, just the fashion way you're used to seeing, is you kind of want to use like bath blankets, ramp them up a little bit, and have the head fall back so that the ear canal matches the shoulder. That should create a direct line so that you can almost stand back there. Now, of course, not it. Bring you back to the lemon score. Neck mobility, obesity. There's already 2 out of 5 are just done. So you don't have any, you got nothing. So sometimes it's not ideal, which would suggest that you use. I don't have to worry about neck mobility. I don't have to worry about much about obesity. And the 3-2-3 is really where I end up having to. If I can't get 3 fingers in the mouth, I only got 2. I might have to go to a smaller handle. The GlideScope Go is portable. This, when you're looking at this, everybody in the room, where the hell's this go? It's in the way to exchange BiPAP and vent. It's in the drug nurse's way over here. She's got one leg in the bed trying to get it done and working around this thing. So this thing's, it's nice, but it's a pain in the butt. This is our new toy. You guys have seen it. This is our new toy. Does what this does. And that's the on button. It's a plug and play.
Put that my nostril.
Plug and play.
Yeah. And this is the S4 compared to this 4. Look at the difference. You realize how much of a difference it is in this. Yeah. Yeah. So a 3 is even.
It's still different.
Yeah. Right. Right. So a 3 might be the way to go, but on here it talked about a 4 was for 40 kilos and up, but there is a big difference. I've used all 3 of these, getting a feel for it in like one patient. And there's one more choice, which is all right. And this says 40 kilos and up. That's where I got that idea. Look how angulated this is. Almost like a U or a J. So for that airway, that you go in and look and you're like, oh my gosh, I can't get, it's up there. It's up there. And they're like, can you hold cry? Can you put pressure? And it's like, I can't get where I need to go. This guy goes in and goes right up where you need it to go. And I've used this, and that one was a game changer in that moment. I was able to hook, like, try that thing, and I put that on, and it's really curved. You're like, you start here and curve it all the way around. Then it went right up under that. Back up a little bit, and then lift, and there it is. And then the wire that comes with that is heavy curve as well. And that will come in at this at 3 o'clock. 12, my 3. And then at 3 o'clock. Go in at 3 o'clock, go down, turn it to noon, which would be pointing up to the sun now. And then as you bend, knee, left, so if I had one where I couldn't even see the cords, all I have is this epiglottis that's just hanging there, but I see the esophagus below it. And no cord view, but I know right behind this big car hood of an epiglottis I needed to get up. And I could get under it, and I could almost flip that epiglottis. and all I could do is get under it and push, and I didn't feel the resistance, and that just takes experience. I couldn't feel the resistance, so I popped the stylet and was able to advance the tube, and it went on clear up to like 24. I'm like, that's clearly in. It's nowhere else, because I would have gotten pressure feedback from any tissue around that. So it's not. So like that's got to be in. So it's kind of a blind, but not. And we bagged, and its end title turned cold and got lucky. But having heavy angulated both things was very anterior. Was able to make it happen. You can also use the stylet, the old stylets that we use for everything else, and those are pliable too. I've not. I like using this with the tools that come with it. That's those toys. Yeah, this end and that end, just plug and play, and it works pretty good. And this will hold a charger off the charger for like, I don't know. We try to use this when it's crowded, or I always thought its main use was going to be when it was crowded. Now I'm going to use it when I think somebody's super anterior airway. That I'm like, maybe this is not going to be enough. What? What? I mean, I'm really bad about studying every step of it in my head. And
Well, once you get used to it.
yeah, I've probably done.
hard to go to something.
Yeah, I did. I think I had 15 intubations and anesthesia, but and had to do direct with all of them. I then came over here, and since I started here, I had a couple that were direct. 17, so I think I've got 38 intubations. So the next 20 were all been with glycogen, and then one with. But this thing, it worked really good for that period. But when you're in COVID land, you don't want to take more equipment in a room, and can keep the camera there and your head back. This is what anesthesia doesn't like it. They're not familiar with it. They don't want. They only want to do what they're confident in, and that's what we want them to be. So, in a code, this is what I wanted it for, because it doesn't take up any floor space. There's already, 8 people in the room, so it takes up no floor space. I like that. Cool. You guys have any thoughts, questions? Anything you ever wanted to ask?
Any questions from people at home? We've got Lisa Surratt, and she says, no, great job.
Thank you.
I have an unknown user. I think Becca's on here. Callie. Okay. If nobody has any questions, I'm going to hang up the meeting. Speak now or forever hold your peace.
Instagram's in where it's gonna flex my boobies.
If you think of any questions, ask
Yeah.
Wayland, okay?
Yeah. I'll be around.